Hi, and welcome back to Architecturally Speaking as we kick off Season 3. I'm your host, Ryan Schwartz, and this podcast is proudly brought to you by the Ontario Association of Architects. We're thrilled to bring you yet another season of great stories, insights, and conversations about architecture. With each episode, we'll continue to pull back the curtain to give you a look behind the scenes with architects and other design professionals to explore housing, urban design, construction, sustainability, and everything else related to the world of architecture. On today's episode, we're talking about hospital design and its impact on our health and wellness. Now, as far as architecture goes, hospitals are notoriously complex buildings, so it's my pleasure to introduce an expert in the field. We have Robin Snell as a director with Parkin Architects. Robin is an experienced healthcare architect who has worked on a range of projects all across Canada for more than 30 years. Robin is an advocate for evidence-based design and leads Parkin's evidence-based design team and their post-occupancy evaluation process. I'm sure we'll get into that. He was recently named a fellow of the Royal Architectural Institute of Canada, and he's vice chair of the CSA Technical Committee for Healthcare Facilities and also active on some other CSA healthcare design subcommittees. He's currently responsible for some of the largest healthcare facility redevelopments in the country, and he's with us here right now. So Robin, thanks for joining.
Thank you very much for the introduction.
It was a long one, so you must have quite a few healthcare projects on the go at the moment.
Our office is specialized in healthcare. We have maybe 340 people across Canada, 3 offices, Vancouver, Ottawa, and Toronto, and we're almost about 80, maybe even 90% healthcare focused. And so, yes, we have a lot of projects on the go, coast to coast to coast.
And I mentioned hospitals being sort of notoriously complicated, complex buildings, and I think that's a good place to start. So why are hospitals such technically complicated buildings, and what are some of the unique challenges with healthcare design?
So agree, that's a great kicking off point, great starting point, and the answer to that isn't a short one. So bear with me, to you and your listeners, what will I go through? Definitely a loaded topic, but essentially by the end of it, I hope it'll help understand why I'm so passionate about healthcare facility design. Essentially, there are a number of interrelated topics, sort of buckets of subject matter together. But to start, essentially, it's a building type that nobody wants to go to. Can be a life and death situation. It can be a traumatic life event, typically a high stress situation. At best case, it may be a healthy birth or a diagnosis or a treatment or a rehabilitation opportunity. But for the most part, it's seldom fun and seldom a building people want to go to. We definitely have to talk about the fact that we live in Canada proudly, and it's a publicly funded system. So both the capital and the operating costs are entirely public. There are some private projects emanating, but our focus is on the public sector ones, and that's where I'll focus the conversation today. It definitely starts with the service delivery model and the functional program. So essentially, in any given community, what are the key services? What are the key requirements? And we all know the pressures related to bed shortages, wait times, staff shortages, outdated infrastructure, tight budgets. And so it's an omnipresent topic for us. And in essence, the service delivery model and the functional program is predetermined largely. We get involved in some master planning with some ability to influence a little bit about what that is, but essentially, once we get involved as the architect, that's predetermined. But at the same time, we do have some latitude to kind of challenge space requirements, adjacencies, flows, and that sort of thing. I can come back to that. So really, that's kind of the kicking off point for us. Operational efficiency is a huge part of everything that we do. There's an analogy that about 15% of the total project cost over a 50 to 60 year life cycle is for the design and construction. A relatively modest cost after that is to maintain the building. And about 70, if not 75% of the total life cycle cost of a healthcare facility is the cost of the service delivery. So in essence, getting to the notion of complexity, good design decisions or poor design decisions can have a huge impact on the 60-year life cycle and the operational efficiency. For us, a big thing we talk about is sneaker time. You can imagine trying to staff facilities, and if we're inefficient, they need to add staff. Their staff have to travel longer. They get less time at the bedside. A lot of movement of goods and materials. So how we plan it is really important for the efficiency. And just as a matter of interest, we worked on a facility in Corner Brook, Newfoundland, where operational efficiency was extremely important to them in a bit of a cash-strapped province. And so we're able to plan the facility about 14% smaller than a typical kind of model facility elsewhere in the country through kind of some really tight planning efficiencies and reduce energy requirements as well as maintenance, travel distances, et cetera. So that can be an important piece. Safety and security has to be discussed, of course. Typically, a post-disaster building, dire need during sort of an outbreak or pandemic scenario, of course, as we just witnessed. But safety security takes on a completely different meaning. Infection prevention and control is the cornerstone of just about everything we do. But also doing things like trying to plan and design so that we can minimize or reduce medical errors, patient falls, patient accidents, improve sight lines to patients. And we also, have to realize that there are also kind of violent issues, abductions, elopements, narcotic thefts, all sorts of things like that. So that's a big piece of what we do. You hit on the fact that they are the most complex buildings technically. I can give an example of a project we're doing in Ottawa right now, Ottawa Civic Hospital. It's a tertiary quaternary trauma center. It's a teaching and research facility. It has more than 46 clinical and support service departments. To give an example of planning the density of it, the podium, independent of the inpatient towers, is 3 football fields side by side by side, with 5 full floors stacked, in addition to an interstitial floor above it. And each one of them has radically different programs and functional requirements. So we have the emergency department, medical imaging, surgery, interventional radiology, dialysis, et cetera, in addition to all the support services in the basement, pharmacies and sterilization, that sort of thing. And so you can imagine some of the complexity of planning that. And as we're doing that, technology is constantly changing. Equipment requirements, robotic surgeries, whereas AI and healthcare infrastructural needs change. That's a lot of the complexity. And in another project I can reference, the Trillium Mississauga project, there are almost 16,000 rooms in that facility. Now, it is one of the largest in the country. So you can imagine the complexity of all the elements that go into rooms, equipment, medical gases, surgical lights, all those sort of
All the
elements and
behind the scenes
requirements.
stuff.
Behind the scenes are tracked using our BIM modeling and data management software, et cetera. So that adds complexity. Next bucket we can get into is codes. So more so than any other building, the codes, the standards, the guidelines, project-specific requirements that are usually embedded as contractual requirements are more rigorous than most other building types. Next fun bucket is procurement models. We might come back to that a little bit. And so given the costs involved, there are a number of unique procurement models, and that makes the implementation interesting. Then you get scratching the surface of a whole range of subspecialty topics. So accessibility, sustainability, complexity of IT systems, acoustics, AV, even something like a heliport design that has a subsection of specialty consultants. So larger projects will have more than 40 different consultants, all sorts of different topics. And then at the core of it is it's still a facility for health and wellness and needs to be a supportive care environment for the patients, visitors, and staff while kind of implementing those kind of more pragmatic aspects. And really, usually it's one of the largest investments in a community. Some can have hundreds, if not thousands, of staff. And it can be one of the primary civic buildings in a community. So that's the umbrella overview of a lot of what goes in to make these buildings incredibly complex.
There's a lot to unpack there, and you really touched on a lot of things, and we'll try and get to most of that stuff. You mentioned, or in my introduction to you, I mentioned that some of your projects are retrofits. Is there a difference between a new hospital building versus a retrofit and the challenges? Are they kind of roughly the same? Any differences to highlight there?
Pretty significant difference for sure. As I hinted at, the codes and standards have changed considerably, and are pretty well set up for new buildings. And so when you start a new building, the expectation to start fresh, start clean, in compliance with new codes is pretty clean. When you get to retrofit pieces, the complexity there, with a lot of complexities, one of them is that they have to maintain full operations while you're doing construction and renovation. And those
You
can
can't
be
just can't
complex, multi-phase. Exactly.
you
You
can't just shut them down for a year.
can't shut it down at all. And so that can lead to, occasionally it's a relatively clean scenario, but for the most part, they're painful, complex, multi-phase renovation projects, in addition to the notion that the existing infrastructure is often very old and, for lack of a better word, decrepit, lower floor to floor heights, limited mechanical electrical systems. And so that it makes it a lot harder, but there isn't usually budget to completely retrofit and upgrade to current and contemporary standards. And that puts us in a bit of a pickle sometimes.
And you mentioned post-disaster buildings, and that's something I just wanted to highlight because some of the folks listening may not have heard that term before. And can you touch on that and where that comes from the building code?
Yeah, there's a couple of streams. So I'll start with the building code side. So obviously, we need and want these facilities to be able to exist in a disaster mode in any circumstance. So I think there was a small earthquake in BC on Friday afternoon, as a matter of fact. So BC, for instance, Vancouver area is the highest seismic zone, risk zone in the country. But whatever it is, with any sort of climate disaster, any sort of terrorist event, the hospital is ground zero in essence, and needs to be able to operate and maintain, emergency power generation, all that sort of thing, for a period of time. And so structural systems, infrastructure systems, all need to be able to kind of crank into an emergency preparedness mode to keep functioning through that time. I will add a substream to it, which isn't code driven, but with climate change, there's a requirement for climate resilient facilities. Global temperatures are increasing, that the erratic aspect of storms is changing. And so how can we design these facilities, not even beyond code requirements, to be resilient to climate disaster?
And how do you do that? That was actually my next question. That was perfect. And all these complexities, and then you layer on sustainability on top of that. How do you approach that?
So sustainability kind of review falls under a few buckets. The first one I hinted at already. So that's kind of the climate resilience aspect, simple aspect. Don't put all your, major emergency switch gear in the lowest level of your hospital where it might be susceptible to floods. Or if it is, you need some pretty very comprehensive mitigating strategies to ensure that there isn't a risk. So that's a quick and easy, tangible example. The next piece is trying to do low carbon healthcare. Healthcare facilities are one of the highest consumers of energy. And so how can we design facilities that have sort of a lower carbon needs? So most major projects now are going to full electrification. That the burning of fossil fuels is essentially behind us, and the exception to that is emergency power generation, which is code driven. And I'm proud to say that one of our recent projects that we opened in Corner Brook, Newfoundland, we think is the first or one of the first zero emissions healthcare facilities in the country. It leverages Newfoundland's high use of hydroelectric power. It also has what we think is the second largest geothermal field in the country of any building type, and the largest in healthcare for the heating and cooling source. So that's something we look at. The third bucket is embodied carbon. And we're getting a bit better at being careful on the energy side. And now maybe the next one for us to focus on a bit better is the notion of embodied carbon, and how much of that is in materials, concrete, steel, insulation, et cetera, is part of where our focus is. Maybe the last thing I'll say quickly is every project across the country has a baseline requirement, usually for LEED certification, but I think we're learning that's almost like a token checklist scenario, and there's a lot more we can do beyond that minimum requirement.
Agreed. Yeah, it helps, but it's not necessarily solving the problem. It's a step in the right direction. But I want to touch on evidence-based design. This is something we mentioned in your bio, and you mentioned too that when a project kind of comes along and it's on your desk, a lot of the program requirements and things have already been decided. So these inputs in starting the design process, sort of where does that come from, and how does evidence-based design fit into that? And what is evidence-based design?
Sure, maybe I'll start with that. So, I think we're all pretty relieved to know that evidence-based medicine is a thing, and when they make decisions about our diagnosis and treatment, that it's evidence-based, and the light bulb went on maybe in the late '80s, early '90s by some researchers and architects that maybe we can make evidence-based design decisions to drive improved outcomes. So the improved outcome might be to try and reduce a wait time, or to reduce infections, or to reduce falls, or improve, patient satisfaction, whatever it is. So you can have a hypothesis that a design intervention will have uh, an anticipated outcome. Um, and then you can do some fairly straightforward research, we hope, to kind of tease out whether that's actually transpired or not. Now, because that's been going on for a while, it's still a long way to go. There's a lot of literature. There's been a lot of research done to date. So our first step is that if we have a design topic that we're struggling with, we can do a pretty good lit search and find out if there's any science essentially to support a design idea or hypothesis that we might have. It is a pretty significant undertaking to do a robust, fully developed evidence-based design research study. And with millions, if not hundreds of thousands of design decisions to make, we certainly can't make them all evidence-based. So it really is a matter of curating some kind of unique and innovative aspects of a given project to see where the evidence can be used. So if you indulge me for a minute, I can talk about a pretty interesting study that we've done. It was partnered with Cornell University. It was related to wayfinding, although the wayfinding was almost a subtopic. It was related to our Corner Brook, Newfoundland healthcare project. And essentially, they developed a technique to use VR and biometric data to track the efficacy of our wayfinding solutions. And in our wayfinding solutions, it's a matter of using visual design cues. So things like accent paint colors, enhanced graphics on the signage, lighting features, whatever the scenario might be. So galvanic skin action, EEG, brain activity, heart rate, even electrooculography, essentially tracking of your retina movement. And so we helped create the study and the paths and the hypothesis, and then they used their lab to test in VR whether our wayfinding cues were effective or not.
That's pretty interesting, and that actually led perfectly into my next question, because I was wondering, you have all this evidence, but then how do you go back once the building is complete, post occupancy, people are moved in and using it, and how do you evaluate how good it is as a building? And I think that's something that maybe isn't done enough, not only in healthcare but in other buildings too. So I don't know. Can you speak to that a little bit on collecting that data? Is there any other methods, or how do we go about evaluating our buildings when they're complete?
So we could talk for 4 hours about this easily. You hit in my bio about the CSA nerd stuff that I do. So one of the standards that I was chair for is for healthcare facility design studies and post-occupancy evaluation. So you've hit on a topic that's near and dear to my heart. You also hit very cleanly on the fact that it is rarely done well. We're always on to the next project. It's seldom funded. It's a really difficult thing to do. At the easiest level, we might get time and resources to do a pretty simple lessons learned scan. We might be able to do some simple interviews with staff and go in and do some evaluations to find out if some of the key design elements we had have been effective, and just essentially pick up their feedback as they go. It is extremely difficult if you learn something on a given project to change. After you've built and occupied and funded your project, there's very limited resources to make any changes. So really, it's about helping with the next project and the next project and the next project. I will reference the Corner Brook study that we're doing. So the first part of the study was to do the VR analysis in a lab. The second part was to actually go do analysis before the building was occupied with volunteers. And then we will go back in a year, which is in June after it's been occupied, to actually test it real time to see how it's been effective, to try and bring it through the 3 stages.
And cost and funding has come up a couple times now, and These are public projects often. There's a lot of public funding and public committees, and this is taxpayer money typically, right? So how does costs, how does that play a role in all this in hospital design, healthcare design?
Omnipresent, omnipresent, constant element. They're usually kind of financial caps to the project. There's almost inevitably value engineering processes, several layers of value engineering processes. There's a awareness of operating cost impacts and what the impacts might be down the road. Um, Numerous submissions, checkpoints, estimates, validation of estimates, third opinion review. It's omnipresent in what we do. We almost call it sort of budget awareness. We're having a user group meeting and they're asking for additional things. We have to say, well, that's a great idea. We'd love to do that, but we have to check affordability on that. Or if this is a great new initiative that you really need, we might have to give up something else. Omnipresent.
It affects basically everything. Do you know, just kind of offhand, is there a cost per square foot for hospitals? And that's just kind of for my own curiosity. I'm sure it's high, but do you know, is there a number for that?
I'd like to challenge you. Want to guess how high?
Ooh, well, I was going to compare
You
it
can
to
pass.
residential. Yeah, well, I'll throw a guess because I was going to guess residential is maybe just kind of as a blanket statement, maybe $400 a square foot. And so hospitals, I imagine, have to be upwards of 1,000, maybe more.
So we're getting towards $1,500, even $2,000 a square foot. Now that's project cost, so slightly different than a construction cost. But the numbers are up there. They're highly, hugely complex buildings, and unfortunately, the cost escalation on materials and trades, et cetera, has gone up. In some of our larger projects, I'll give an interesting example. The Mississauga Trillium Hospital, the construction duration will be 10 years. So essentially, it's a 10-year project to get the major project built and then come back and decommission the old hospital and do some minor renovations, et cetera. So you imagine if you're a drywaller and you've been asked to give a price 10 years out, that's a pretty tricky thing to analyze.
So we've been talking kind of at the sort of a bigger scale, bigger concepts at a high level. So if we zoom in a little bit to the more granular stuff with hospital design, and we're looking at things like interior design, and you mentioned wayfinding, acoustics, lighting, kind of those sort of day-to-day things that people might notice when they're really in that space. What kinds of things are going into these hospital designs, and how do they affect the people that have to go there?
Yeah, so great question. Fun to funnel it down a little bit. And I mentioned the notion of outcomes before, and any aspect of design, including interior design, can have a significant role to improve outcomes. And so I'll get into some of the ones that you mentioned. So wayfinding is an interesting one, another one near and dear to my heart. And we mentioned before that these are stressful times. These are stressful visits, and they're incredibly complex facilities. Some are smaller, but usually they're fairly complex facilities. So finding your way around is difficult. And it's also a bit of an imposition on staff if they're constantly being asked, how do I get to this? How do I get to that? And so our ability to work with signage consultants and to design an intuitive wayfinding system, it is really a huge priority. And oftentimes when we do visioning sessions with clients, they'll rank that among kind of like a top 5 kind of priority aspects. And so things like how we plan, how we create landmarks, how we draw the eye to landmarks, how we create visual cue, a hierarchy of spaces. You don't just have to find your way to the space, you got to find your way back out of it again, and then maybe probably to your next diagnostic location. So sometimes your visits can be fairly complex. So that's a huge aspect, and we pay a lot of attention to our design and cues for that. Clinical planning is essentially the cornerstone of what we do. We can design a sort of a beautiful aesthetic facility, and we can have astounding infrastructure, but for 60 years, they've got to operate that thing. And if we make some poor decisions and it's awkward and difficult and inconvenient to plan and flow and work through these spaces, the adjacencies aren't right and that sort of thing, that's really where we get ourselves into trouble. So that's a huge part of what we do. And the efficiency I already mentioned is key. I like that you mentioned acoustics. So, things like sleep If you're in an inpatient unit, and we can control the acoustical environment and improve the acoustical environment, your sleep pattern is probably improved. Things like privacy and dignity and speech intelligibility is important, so that when you're registering as a patient, your confidential information isn't heard, um, which is often in an open concept space, so that's difficult to do. So acoustics are huge. Light, natural light, access to views, huge aspect. A lot of patients and family members like the ability to control their environment, so to have different options and arrangements for the environment. But of course, code blue, you've got to kick into gear and have the right kind of lighting for safety. If I could keep going on a few more, cleanliness is extremely important. Um, we're really working hard to create an attractive aesthetic environment. At the same time, we can't create things like dust lifts and shelves. We need to make things, impervious materials, easy to clean. When they turn around a hospital room, the cleaning agents that they use are pretty intense. And so it needs a lot of durability to sort of withstand and hold up to the cleaning. So for instance, we're almost never permitted to use, wood or wood veneer elements in a patient room. It's usually kind of a wood look scenario by standards. So that's a huge piece. And then you get it kind of into the layers of art and decor and view and access to nature and positive distractions. All great opportunities, things like abilities to connect to local community through the artwork that you're creating. We had an example in Ottawa, Oakville Hospital, Oakville Trafalgar, where they actually went and got one of the art curators from the local gallery to essentially curate a permanent rotating art program with a really impressive level of sophistication to it. So there's lots of opportunity in interior design.
Just makes it kind of a nicer space, yeah, for potentially an unpleasant visit. And there's the old architectural maxim, sort of form versus function. Which one comes first? Which one follows the other? And pretty much everything we've talked about so far here is kind of function driven. So I think that for hospitals, at least, it seems obvious that function is kind of, at the forefront. That's the important thing that we're trying to manage here. So how would you describe sort of the core purpose or the function of a hospital?
Um, so I mentioned earlier that it's really about service delivery. And so your facility might be anything small. Maybe it's just a small medical imaging facility and you're trying to kind of maximize efficiency and throughput and get people to their imaging modality as quickly as possible, up to the complexity of, the large 3.3 million square foot hospital with 46, 50 departments. It really comes down to adjacencies, flow, circulation, orientation on site, sight lines. There's just such a myriad of different complex factors that essentially drive those elements. Essentially, what we do in the earliest stages of a project is we create sort of a blocking stacking strategy, which is essentially on a floor by floor level, as well as a stacking level up through the hospital, where the most critical adjacencies and relationships need to be. So just a healthcare 101 is, you have your emergency department. You have to get from emergency department really quickly to either critical care or surgery. From surgery, you have to have a direct connection to your medical device reprocessing area. From there, you want to be able to get to your inpatient units quickly and all that kind of stuff. So these key adjacencies essentially drive core elements of the function, and the other ones kind of work and fill in and backfill around that. Yeah.
Yeah, and
Form follows function.
yeah, and a lot of this, I can see that it might be easy to sort of forget about, and all this complexity, all these, adjacencies and programmatic efficiencies. It can be, I could see the potential for sort of forgetting about the individual patient, the person that's in there at the end of the day, and like the sort of the function of the hospital is to promote their healing, or something along those lines to allow them to get better. Um, how would you describe that? Would you, how do you balance that? How do you
So
bring that in for the person that's actually spending the night there?
yeah, so one of the things that we're encouraged to do, and we take great excitement to do, is to consider the patient journey. and almost sort of game or track different scenarios of a patient journey. You're coming in for dialysis, or you come in as a through the emergency department, or you're expecting mother with a complex precondition or something like that, and we'll game and track the different scenarios and try and understand the flow and the path and the environment that you're going to see and perceive along the way as you do that. And as much as even, tracking your ability to be an inpatient, and I'm an inpatient and I'm feeling well today and I want to be able to have space to ambulate, move around. Is there a spot for me to rest? Is there a nice view? Is there a good lounge? So that's the key part of it. And so, in addition to tracking the departments, we're also trying to create these kind of patient and staff experiences as they go. So I'm glad you hit on that. So in a fun example I can give, again, going back to the Corner Brook Hospital, is to try and maximize their efficiency. We compressed the floor plate and stacked the building and got the inpatient towers higher up, which wasn't in the program or wasn't anticipated in the master plan. The point of that, if you've ever been to Corner Brook, Newfoundland, is it's essentially a beautiful mountainous area. And we were able to get the patients up much higher in the building with spectacular views, 360 degrees towards the harbor and towards the mountain areas, which do, including, mental health lounges and things like that, terraces, with great views, access to natural light. And so the point is that it's not just the efficiency, but it's the quality of the care environment at the same time.
Yeah, it doesn't necessarily have to. I mean, on one hand, it has to be a sterile environment for cleaning and functionality, but also, people have to spend time there, and you're trying to make them comfortable and allow them to rest. You mentioned one thing I want to touch on is that these projects and healthcare facilities and hospitals, they're often a sort of a cornerstone in their community. And this idea of, you just sort of mentioned it too, like maybe going up to the top floor and you're getting a nice view and you have family coming over to visit. And what are your thoughts on hospitals as kind of a community hub? And it's not necessarily a gathering space where you want a lot of people to come necessarily, but maybe you do. I don't know. Is this a sort of a missed opportunity for hospitals?
Potentially, an interesting point of debate, and it varies widely. Some facilities end up becoming fairly standalone. Um, New greenfield project, lack of good property opportunities, and so they can be moved to kind of a suburban location or something like that, and a little bit harder. Others are deeply embedded in urban situations. I can think of an example. The CHUM Hospital in Montreal, it takes up 2.5 city blocks. I think it has 2 metro stops embedded sort of within the facility. There are cases where we're trying to incorporate public spaces and public thoroughfare, and I think that CHUM Hospital is one of the better examples in the country. Food courts, exhibition spaces, etc., are used, and there is ability to pass through the hospital. On the flip side, if you're the director of infection prevention and control for that facility, you don't necessarily want people coming in and contracting infections. You don't want people bringing in more infections, so people get a little bit nervous about that sort of thing. A fun project example we did was an community outpatient facility in the outskirts of Halifax, Bayers Lake Hospital. They were expanding into a bit of a suburban area close to a really good sort of green walking path system in their park system. And so we actually were able to incorporate an extension of the walking paths for the communities to get through there. And a fun thing our landscape architect did is they incorporated berries, strawberries, blueberries in the patch. So we knew it was successful when people from outside the community were coming to pick berries. I think the staff were a little miffed that they were losing their berries anyway. So it can be done. It's being done a little bit, but it is tricky at times.
Yeah, that makes sense. And speaking of infectious control, I kind of want to shift gears a little bit to just sort of some lessons learned. And obviously, we've had a COVID pandemic not that long ago. Are there any lessons learned from something like that, and just designing for flexibility and the future, and trying to future proof for unforeseen circumstances that we don't necessarily see coming?
Yeah, so two very different topics. So remind me, I'll try and come to both of them. So we'll start with the COVID thing. So yes, of course, SARS to start. So a lot of the lessons from SARS drove a lot of revised standards work. And now COVID is done and triggered a lot of revised standards work. And just for fun, the Canadian Standards Association has a standard for healthcare facility design and construction, and it just rewrote and republished and changed some elements to incorporate lessons learned from COVID. And then also there's one for the design of HVAC, heating, ventilation, air conditioning system, which you can imagine in healthcare to reduce infection is a colossal requirement. Plumbing systems to make sure Legionnaires' disease, etc., don't proliferate. So lots of requirements. So those were also rewritten post COVID. Again, we could talk all day, but I'll kind of hit on some really high level things. First and foremost is the notion of effective streaming and screening, and the notion of segregating flow and circulation between potentially infected or non-infected, taking up more space than was anticipated. And so the notion of planning lobbies and entrances and vestibules and having alternate means of access, staff access, is an important piece. Great debates over how many isolation rooms, isolation wings, isolation units might be required. And even, the notion of whether OR rooms, which traditionally didn't have isolation features, which is essentially anti-rooms and HVAC parameters to facilitate. So there've been some changes there. Simple things like you probably saw through the pandemic, constant changing for the staff of their PPE for safety and reduce infection. And so space allocations to do that, the micro detail of how you don and doff and dispose, et cetera. And one of the things we even saw is that staff during COVID couldn't leave their units, couldn't leave their departments, but had to socially separate. And so, do we have adequate space for staff to go and get rest and respite and change and rejuvenate within units without necessarily having to leave a unit or go too far? So anyway, that's the tip of the iceberg, but there's lots more. Flexibility is also a huge thing. There's a cliche saying that the only constant in healthcare design is change, ever changing, ever evolving. It really starts at the master planning process, which in healthcare is a bit more about the service delivery and approvals process than it is about more traditional kind of university campus master planning or something like that, is to differentiate. But how can we plan a campus or a site or a facility that has long-term expansion kind of built into it without spending too many dollars on day one on infrastructure that may or may not be used for expansion? So that's always an important part of discussion. When you get into the facilities themselves, there's a lot of strategy. Again, it links to the adjacencies of flow about whether you can expand, whether you can have shell space, whether you can have soft space that can be decanted to allow potential expansion capabilities. Is something we pay careful attention to have key major impact facilities like surgery or emergency or in fact critical care with the ability to expand as time goes on. We all know you'll occupy a brand new hospital on day one and there still won't be enough beds in it. Then there are simple things from an infrastructural standpoint. So we'll over plan our shaft sizes to allow a little bit of space. We'll over design electrical rooms, TR rooms a little bit, to the IT rooms, just to allow additional change, expansion, et cetera. Those are the kind of a lot of the requisite things. So hard to predict, so hard to guess. And like I said, that balance between spending on day one versus being future ready is a tricky one.
And there is a lot of things to balance, and there's a cost associated with everything. We talked about that. So, in a perfect world, in the future, maybe if money's not an issue, what kinds of things would you incorporate in a hospital? Like, what does the hospital of the future look like in a perfect world? What kinds of things would you sort of double down on or integrate that you don't necessarily see all the time?
Definitely a tricky question. You have the wrong guess to try and think of a world without constraints in healthcare because they're so omnipresent and the story of our lives. But and it's so hard to know with AI where things are going and what sort of diagnostics or tools or treatments can be done. Virtual care is a huge unknown entity about how much can be done virtually, remotely. Yeah, a lot of emerging technologies that make it difficult to predict. There's also a bit of a trend right now, and I mentioned a couple of the kind of mega hospitals that are coming up, but there is thought that maybe the mega hospital isn't necessarily the best thing for the community or the most cost effective way to deliver healthcare. Huge debate. We could debate that one, pro and con, for a long time. And so the notion to kind of break down the projects, distribute it, and spread them around the community a little bit. And it may not necessarily just be cost driven, but it might just be a better way and a more effective way to deliver care. You probably have heard a bit more about kind of community outpatient health facilities cropping up and sort of diagnostic facilities. And, can you put them in a building type that's a little bit more cost effective? And sort of not necessarily linked into the infrastructure of a large hospital. So that's where a lot of things are moving. But, maybe you also threw in there, I think I heard the words, the perfect hospital. And this is an OAA-based podcast, and maybe part of what we're skirting around is that healthcare architecture is so mired by the constraints, as we've been talking about, that it's difficult to really focus on the architecture and the design and the urban design. And so with that lens, the perfect kind of sweet spot is where we can meet all the complex functional parameters and efficiency and future planning, all that kind of stuff, and still really have good, proud architecture embedded in it. And I will say that's essentially the hardest thing to do.
That's a great answer. Yeah. And I guess just maybe to reframe that question a little bit is what kind of lessons, there's so much research done on hospitals and healthcare design. What kind of lessons can we take from that and apply to other buildings? Is there anything that jumps out that we could be adopting to, buildings that are a little more common, condos, schools, that kind of stuff?
Maybe not condos per se, but maybe things like schools or universities or a term we didn't get into yet a little bit which came into effect about 10 years ago, is lean, sort of taking industrial manufacturing efficiency process and methodology and trying to see if that can be applied to the activities in healthcare to make them as operationally efficient as possible. So if you're doing something like a lab or a school or a facility like that, even something like a library, how can we, plan them to be as efficient as possible? Maybe there's this lesson learned. We are starting to see evidence-based design in some other building types. So lab corrections, education is a great example. Are there some, commercial office use? What can you do to improve productivity? What can you do to improve employee satisfaction, all that sort of stuff? So I think evidence-based design is starting to make its way there. I think we saw during COVID that a lot of building types had to pivot and change. And so maybe there are a few lessons learned from COVID as far as streaming and segregation and cleanability, et cetera, when that happens. Maybe a key one, which we haven't really gotten into too much, is healthcare is really leveraging, most building types are, smart hospital technology. In healthcare, there are so many systems that need to be integrated: patient records, imaging records, building automation systems, smart wayfinding, tip of the iceberg. There's security, et cetera, et cetera. There's so many integrated systems, more so in healthcare than any other one. So the digital infrastructure that's being created to service that kind of infrastructure probably has some transferability to other project types. Typically, they were softwares that never spoke to each other and separate systems. So, and I mentioned before the BIM modeling and the asset tracking and the data information about equipment, et cetera.
Yep.
Maybe another piece.
Things are getting more complicated. Yeah, tracking those and looking for efficiencies and things there. We covered a lot. I want to be respectful of your time here too. Is there anything that we haven't touched on that you'd like to mention? There's a lot.
Yeah, there is a lot, and this kind of feels like maybe the tip of the iceberg, and there's so many different topics to be drilled down on. But one that we didn't get to, if there's time, is procurement models. I sort of hinted at that, and that really is something essential that drives a lot of our work. Is it okay if we
Yeah,
get into that a little bit?
Yeah.
Okay. So Generally, we find, obviously, public funded healthcare. We want a public procurement process, and need to encourage that. Generally, what's happening is that government agencies, for any project, let's pick a number, $100 million or more, um, don't want to go to a more traditional stipulated sum or design bid build scenario, because too often there was overage in both budget and schedule. And it was a lot harder to control the risk of that. Anything under 100 million, there's a bit less at risk. So over 100 million, there's a new procurement model, well, new 20 years ago, British-based model, primarily Australian, which is essentially a private-public partnership. And that's where a consortium would be essentially hired by the government agency or the healthcare facility to, in a competitive forum, to design, build, finance, and potentially even maintain the facility over a 25 or 30-year period, and almost like a leaseback arrangement, receive kind of monthly payments, and then turn the facility back over to the owner. Like I said, this was primarily devised to reduce risk of schedule and budget overruns. So the private group holds that. The key to it is, though, that it's not private healthcare, because the healthcare service delivery is 100% by the healthcare authority and publicly funded, and then it's turned back over. In essence, what it allows the government to do, in addition to the reducing risk or eliminating risk, is do multiple more concurrent projects rather than being kind of out of pocket for a smaller handful of large projects, and essentially deferring the payments over a longer period of time. And so I talked before about bed shortages. That's probably the highest priority. And so doing everything we can to get as many beds and ERs and ORs into the community as we can. And so it's been an advantage to do that. We could talk for hours about that system. It's a complex system. It's a little bit controversial at times. It is evolving, thankfully. It's evolving to develop tools that make it more collaborative. And we think sort of their models are coming out of BC. There's an alliance model version, which is like IPD. And just trying to make it a bit more collaborative, interactive. And essentially, we hope driving to, sort of going back to the architectural piece, that sort of improved outcomes. I could talk all day about that too.
No, that's good to know that things are evolving in that right direction. And actually, one thing that we maybe should quickly touch on as well that we didn't is accessibility, and that's another huge topic that we could spend hours on. And in fact, there is a whole episode on that we did a season or two ago. But these are vulnerable populations that are inhabiting these buildings. How does accessibility factor into all this as well?
Yeah, definitely glad you brought that back, because when you sort of rank the key and core criteria, when you're visioning with a client early on, and they might pick wayfinding as sort of fifth or sixth most important to them, accessibility is usually kind of 2 or 3 or something like that. Hugely important to corporate organizations from a cultural perspective, and it gets really complex, and it's not just sort of code-based accessibility requirements are almost the absolute bare bones baseline. There are numerous standards, guidelines, written project requirements. And the difficulty is that it starts to delve into the world of equity and inclusivity, human rights. And then it also, in healthcare especially, gets complex in that you might have various impairments. So it could be mobility, cognitive, visual, auditory, any range, and bariatric requirements. So patients who have heavy body mass, any range of requirements at any given time. And what's interesting for us is that the code standards requirements are often competing. So something that is a benefit to someone for visual acuity may be detrimental to someone with mobility or cognitive challenges. And so it again, to use the word omnipresent, is omnipresent in everything we do. Proudly, Parkin opened a division called Parkin Accessibility a couple of years ago. And so we have kind of specialists who focus on nothing but accessibility and help us be aware of how to navigate essentially where you often end up with competing standards and requirements to do essentially what's best for the project and best for the kind of majority of the groups that you have. So that's again a quick summary, but a huge topic, and I'm glad you got back to it.
Yeah, I mean, we could unpack this stuff for days. There's lots here. So I appreciate your time today. If people want to get in touch with you, they can probably reach out through Parkin Architects. Is that probably the best place?
Yeah, you can go through Parkin Architects. You'll see us online. My email address is straightforward, snell@parkin.ca.
Perfect. Well, that'll wrap up this episode, the first episode of season 3. So please leave us a quick review, share with your friends. This will help to provide some more episodes in the future. Architecturally Speaking is available wherever you get your podcasts and also on the OAA's YouTube channel. So check that out for the full video version of today's chat. And of course, if you're interested in learning more about anything that we talked about today, you can check out the Ontario Association of Architects website for lots of additional information. It's a fantastic resource for the public and architects alike. So you can visit oaa.on.ca. And until next time, I'm Ryan Schwartz, and this has been Architecturally Speaking. Bye for now.